Well, good morning. It's a pleasure to be here with you clinicians admitting people. I'm Leonard Hock. A pleasure to be one of the physicians at Cornerstone, soon to be chapters and Cornerstone. And today we're going to talk about talking. We're going to talk about the difficult conversation. Now, you all as admitting folks your job description is to admit these patients and their families into Cornerstone so that they can receive the grace and care that we provide them in hospice. And the job description and the Medicare regulations that were updated in 2008 define your role very clearly. You need to be nurses, you need to be able to understand the admitting process, the documents that are required, the explanation that when someone joins a hospice, that they're willing to give up that acute curative care, right? Is that what you talk about? You try to get the DNRs in place. Now you probably are electronic, maybe sometimes paper, getting the signatures and getting them admitted to hospice. Yeah. But what happens, it's not in your regulatory job description that you are the one that steps across that threshold and all of a sudden find yourself in a mess. They don't know what's happening. Nobody's told them about hospice. They haven't heard about a life-limiting terminal prognosis. Does that ever happen to you? Or does that ever happen to you every day? Exactly right. That's exactly right. So how do you have this conversation when you have stepped across that threshold and you're caught? And you have to figure out immediately what's going on. Do you think you're pretty good at reading the room? The sad daughter, the angry son, the family in conflict. Some people say, keep treating. Other people say, Mom wouldn't want this every day. Yeah, of course, that's right. So how do you all handle that? How do you handle that? What do you do when it comes to that conversation and you're there? You know, once you've stepped over that threshold, you can't step back and say, oh, never mind, let somebody, you're there and you're representing Cornerstone chapters, and what do you do? So what do you think, and this, I want you to answer, what do you think is the style you would use to do that? Do you think you have to be calm? Yeah, is the situation always calm? No. I term the situation often emotional chaos. Even if someone is resolute and they know they may want to get into hospice, so they get away from all that stuff that's been bothering them, feeding tubes, tests, ventilators, dialysis, they just want to be with their cat. They just want to be home. They just want to be surrounded by love and have peace. But that isn't what you walk into. You don't walk into peace, you walk into that emotional chaos. So what do you think are some of the other qualities or attributes that you bring? Do you think are you nice? Are you nice? Compassion. How do you exhibit that compassion? That's exactly right.
I think we present calmness, it helps calm down the chaos, because if you can lead.
If you can calm the chaos, that's exactly right. And showing compassion, empathy, that's exactly right. How do we demonstrate that? How do we let them know that we're compassionate and empathetic to their situation? Talking, touching, yeah, that's right. Body language. What kind of body language? This is the old active listening talk, remember? Where you lean in and you put your shoulder, you make eye contact, you do what husbands usually do, auto nod, right? That shows that you're caring and listening. So the talking is very interesting. It is more about listening that shows your concern. And we listen to all kinds of things. So being kind and being calm and being empathetic and compassionate and listening are all good attributes. But it sometimes doesn't work. And so we need to have a bit more than that, So you all, who here thinks they've been doing this the longest, admitting patients into any hospice? How long? 20 years. 20 years? 20 years? Anybody longer than 20 years? Maybe somebody in the audience is longer than 20 years. So one of the things we often hear is that practice makes perfect. 20 years, you've done a lot. Well, practice does not make perfect. Practice makes permanent. What we did wrong 20 years ago is what we're doing wrong now. Not that you do anything wrong, but that's just the way it goes. Practice makes permanent. Perfect makes perfect. And that means we have to keep learning all the time. And before we started the video, I was telling you the different things that I have done. And the reason that I've done several things in my career is because I continue to learn and learn and learn. It's the reason I haven't thought about retirement. It's the reason I want to work with Chapters and Cornerstone, because every time, and my job as a palliative physician is to intentionally step into that emotional chaos and see if I can bring empathy and compassion and listening and calm to that chaos. But we have developed now active prescriptive tools. Prescriptive, that means there's A, B, C, D. Do the first thing, do the second thing, do the third thing, do the fourth thing. And we're going to talk about those prescriptive methods. When we walk in to these rooms, we often are confronted with the 5 emotions that Elizabeth Kubler-Ross told us about in 1969 in Death and Dying. So what is the first human emotion when we go in and we start talking about the diagnosis or the life expectancy, the prognosis, the terminality? What's the first emotion that we're often confronted with? Denial. Shock, disbelief, and denial. Now, Elizabeth Kubler-Ross said these are stages of response to bad news or grief. So it was denial and then anger or bargaining, and they kind of go together. It can't be true, I want a second opinion, the x-rays must be wrong, so that's still the denial, the bargaining, and the anger. You know, I never liked this hospital anyway, I want to go to another hospital, this nursing home is terrible, shouldn't be here. Probably never heard that about a nursing home. We hear that about every nursing home and every hospital, because the families are angry, and in denial and bargaining. And then, after denial, anger, bargaining, comes depression, and then finally acceptance. But acceptance doesn't mean, oh, now I get it, it's okay, mom's going to die and you guys are going to take care of her. That will never happen. The acceptance is not the emotional acceptance, because that sense of loss, we talk about it as anticipatory grief before the loss, and then we talk about grief, and then we talk about bereavement, and then we talk about normal depression, and if that normal depression and grief lasts more than about 1.5 years, we call it depression, and then we make referrals, right? So those emotions are always there. The acceptance is an intellectual acceptance that they understand what's going on. They may hate it, it may break their heart, but they understand that. So those are the emotions that we go into, but I think they're not stages, they're all mixed together. We throw all these emotions. So you'll get somebody who you think, finally they get it. The daughter finally gets it. She has been so sad and so angry, but our aide goes in there and comforts the mother, and she's like an angel to the family, and they finally get it. And then you hear a story that they don't believe it's really cancer that spread. There'll be denial 3 months later. So these emotions are real and they're powerful and they never let go. So in our business, in our lives, what are the 2 emotions that we hold on to in the face of bad news? Hope, exactly. We hope, and that fits into the anger and bargaining. We hope that the second opinion will be a different answer. And the other is optimism, that optimism. So when we ask a family, what do you want us to do for your mother? What's the one-word answer we often get? What do you want us to do for your mother? Everything. Yeah, I've never had a family that said, you know, we really love her. She's the matriarch of the family. She's so important. But let's only do about 85% of the stuff you can do. Because of optimism and hope, if we do everything 100%, maybe something good will happen. But then that carries us down the road, that optimism and hope, and we never let go of that. As long as I've done this, and as intense as these emotional, chaotic meetings can be, if something happened to my wife, I would be a husband. I would not be a professional who talks about this conversation. I would have hope, optimism, I would have denial, anger, I would have bargaining, God, let it be me, not her. Hear parents make that prayer. So in optimism and hope, when we ask, what do you want us to do? This is before admission to hospice. What do you want us to do for your mother or for your wife? The answer is everything. And the other thing that we often hear in that hope, when somebody may be in their last days of life, they may be in the intensive care unit clearly declining, and the family, where all the specialists, and of course we have a specialist for every system. We have a nephrologist and a pulmonologist and a cardiologist, infectious disease, neurologist, a critical care doctor, and everyone agrees that their system is declining and cannot recover. This patient is terminal. And when we talk to the family about that, they often say, but we're praying for a miracle. Yeah. Ever had the miracle? Yep. Of course. So how do we handle these difficult conversations? And I want you all to be interactive. How would you handle you're walking in, the adult daughter of her 80-year-old mother, third hospital admission in the intensive care unit, and the daughter wants everything, but everything won't make a positive difference. So how do you talk to the daughter? What would you say first?
I'd probably ask her what she knows about the prognosis and what her physicians have talked to her about, and then that gives me a starting place to know where to jump in.
And I think that's a great answer. What she knows, what the doctors have told her, and then that gives you a place to start to build your conversation. So I think the what she knows is important, but I will tell you, she won't know the prognosis because there's no acceptance there. There's still denial and bargaining. And it's been my experience, forgive me, doctors don't tell patients and families the right news. If they did, you wouldn't walk in to be the first one to ever break this bad news. Somebody would have told them. Your kidneys aren't working, your heart's getting weaker, your mother can't breathe, she's had a stroke, and she's got multi-drug resistant infection, she cannot get better. She better go to hospice, and then the family would say, oh, we hate hospice, sounds like dying, we don't like that, we want her to live, we're looking for the miracle, we're just hoping maybe if you got a different infectious disease doctor, things would be different. That's the bargaining. That's the hospital shopping. Well, we didn't like that hospital. Hospital was fine, but the news wasn't good. So we want to go to the next hospital, and the news is the same, so they want the next. So doctor shopping, hospital shopping is part of bargaining based on the denial of the prognosis. So if the doctors had told them the right thing, the truth, then you would be past that. But the cardiologist might say, in the face of multi-system failure, with an ejection fraction of 25%, normal's 55%, but her heart's still strong. I don't know, have you ever heard, but her heart's still strong? Yeah, we've all heard that, but her heart's still... Well, if your heart's still strong, which one of those two positive emotions comes up right away? Optimism. Her heart's still strong. That guy said her heart, if her heart's still strong, everything else will be okay. Well, it won't be okay. It won't be okay. Any thoughts about where we are now? So we're going to talk about how to go into the room. So for me, my prescriptive method, my 1, 2, 3 approach is I go to the door and I knock. Now, I do this in the intensive care unit where the slider doors are wide open and the environmental services are in and out, sweeping the floor, and the food service guy bringing the Jell-O in. The patient can't eat anyway, but they still get a tray. They're going in and out of the door. I do this in nursing facilities where two people are in the room and the door's wide open and the med tech's going in and out. I knock at the door. And what does knocking at the door do? What does it signify? What message am I sending by knocking at the door?
Permission.
Yeah, that's your space, and I'm respecting you, and exactly right. I'm asking permission to come into your space. Do you think other people do that in healthcare? When you go to a home, you do knock at the door or ring the doorbell and hope the dog doesn't bite you. But you knock at that door. But inside, I even knock at the bedroom door when we're going, or into the family room door, I knock again. I want to send the big message of respect to them. That's your space. Please allow me to enter. The next thing that I do is to acknowledge them. Oh, Miss McGillicuddy, and are you Janet McGillicuddy, her daughter? Nice to meet you, Miss McGillicuddy. I name them by name. I don't say, oh, are you the wife or the significant other or the partner or the daughter? I try to name them by name, and I ask them, and if you ask them their name, they feel valued. There's nothing wrong with asking them who they are and then how would you like to be addressed? Would you like to be Janet or Miss McGillicuddy? How would you like? And you say it doesn't matter with more important things, but it does matter because we're sending the message of, I want to know you personally. I'm not just talking to patient in 3B. I'm talking to you, Miss McGillicuddy. So I introduce. The next thing, I acknowledge them. The next thing is to introduce myself. And I didn't bring my stethoscope in, but it's often draped over my arm. But I introduce myself as Leonard Hock, not Dr. Hock. That sounds like I'm putting on airs. And you all are dressed professionally. I dress professionally. So I'm saying, I'm Leonard Hock, and I'm here to help. I'm here to help. Now, my conversations are planned every day. I'm consulted in palliative. So this is what I do every day, conversation after conversation. Now, this conversation used to be called breaking bad news, right? Breaking bad news. It's not your job to break bad news, but it's your job to break bad news when nobody else has and you've been called on to admit the patient. But breaking is a bad word, and words matter, because words evoke these emotions of denial, anger, bargaining. And actually, it's been very clear in research and in my studies that if we use negative words, the conversation stops. The patient and the people who love them, that's who I call family, will go into, oh yeah, but they're not listening anymore. Because when you use a negative word, which emotion comes up first? Denial. Denial and disbelief. So they've stopped listening. They've stopped the interaction. They've stopped decision making. And our ultimate goal is to have a quality decision. Not the decision we coerce them, because we don't. Not the decision that we want them to make, but the decision that is a quality decision. So that quality decision can't be based in the middle of emotional chaos. So, and the reason that we can't make good decisions is because we're in a state of denial and anger and bargaining. So somehow we have to defeat denial. Do you all have any tricks to defeat denial? Any tricks? What do? Deny, deny, deny. They're in a state of denial. You know.
Actually trying to acknowledge, what is it that they're seeing, what is it that they feel that they want? Because usually what they want is, it's not going to happen. It's not based in reality.
So that's a great...
We need to bring out.
So that's a wonderful several-part answer, and they're all wonderful. So we ask, and that's the essence of this talk, and we want to know what they want. We do want to understand their understanding, but we don't get it by asking what the doctors told you. We ask them by asking what they know. So after I knock, acknowledge, introduce, And when I introduce, hi, I'm Leonard Hock, I'm here to help. Because they're in a state, do you think the thoracic surgeon says, I'm here to help? They are there to help, but do you think they say that? No. You think the infectious disease that's specialists looking at the antibiotogram to see whether Mirum or Timentin is the best antibiotic, do you think they go in and talk to the family and say, I'm here to help? No. So knocking, introducing, acknowledging, and telling them you're here to help is very, very powerful. And then the next thing that I do, sometimes it's impossible in the emergency room or in a chaotic environment, but I will go to extremes to do the next thing, and that is sit down. Right now, I'm dominant in this room, right? Not just because I'm older than everybody and because I'm a male and because I'm wearing a tie and because I have a mustache. It is because I'm standing up and you're sitting down. So right now, have you figured out that I'm a nice guy? Do you think I'm a nice guy? I seem to be. I'm a very nice guy. And you need to be nice, guy or gal. You need to be nice to be in this profession and show compassion and empathy and caring. So we're nice. But how am I talking to you, nice guy that I am? How am I talking? I'm talking down to you because you're down there and I'm up here. So I'm dominant for all those older guy, coat and tie, so I'm dominant, but I'm dominant because I'm standing up. So I will do almost anything to sit down. And I'm serious about that. I'll stop the conversation. If there's a guest chair in the room, in the home, in the hospital, in the nursing home, I'll use the guest chair. If there's not a chair, I'll borrow one from the next room if there's an empty guest chair. If it's not there, I'll go to the nurse's station and get a guest chair. If I'm in the home, I will ask, do you have a chair I can sit on? A folding chair, a chair from the dining room, can I sit down? In the room, I have frequently taken the bedside commode, closed the lid, and I'll sit on that. You all who are nursing home experienced know you never sit down till you make sure the surface is dry. Right. So I sit down. Now, even now, talking to you professionals, feel how it's changed? Because now I'm eye level with you. I'm still the professional, I'm still the senior guy, still have a coat and tie, but now we're on eye level, which is human level. And now we can talk. And you started off by saying one of the things we do is talk. Well, we do talk by introducing, acknowledging, and saying we're here to help. But every time we talk, we have the opportunity to say something that causes denial. I mean, people have optimism and hope, and they don't want to hear any bad news, even if they know bad news. Even if they're trying to get to intellectual acceptance, every time that we say a word that causes them to think something bad, then they'll go back to that state of denial. So there are a glossary of terms that we should not use. So we should not use cancer. Doesn't that scare people to death? Yeah. We should not use end of life, terminal, or dying. Those things are horrible, aren't they? And people will stop listening because they don't want to think someone they love or care about is terminal, at end of life, dying. They don't want to hear that, and they'll go into denial. And I will tell you, even if they keep looking at you, they're not hearing you anymore, because that denial just puts this concrete curtain in front of any more words. Any more words. You know, too, there are some good words that are bad words in our business. Good words that are bad words. Words like improved, stable, or better. So if the critical care doctor comes by the ICU and says her potassium has improved, normal's about 4.5. Her potassium was 2, now it's up to 2.3. Now, it's still low enough she'll die from it, but it has improved. But what happens to the human heart when they hear the word improved?
Latch on.
That because it's optimism, it's hope. Something has improved. Or the podiatrist comes by the nursing home and says, that fungal toenail looks better. Well, that's a fungal toenail. She's dying of end-stage renal disease, aspiration, dementia, and she's got a stage 17 something on where her sacrum used to be, right? But her fungal toenail is better. And what does the family hear? Let me get a hold of everybody. This doctor just came by and said, Granddad is getting better. So improved, stable, and better are good words that cause that optimism. And they don't hear potassium or toenail or blood sugar. They hear the one I love is improved, stable, or better. So it's important that we try not to use words. We can be affirmative without using words that evoke optimism. And I bet all of us have done that. Have you used those words? Of course. Once in a while I can hear it coming out of my mouth and I grab my tongue and stop so that I don't say improved, stable, or better. Well, she can't leave the hospital and go to the nursing home yet. Her blood pressure is too low. And then I say, well, but it's stable. Uh-oh, if it's stable, things are getting better, right? So I think that's important. So defeating denial, because as long as they're in denial, haven't you come back to the office or had your team meeting and said, you know, I tried 3 times. I went by that home 3 times, and those people have got a skull this thick. They must be low intellectual folks. They don't understand anything. They're in total denial. Have you ever used the words total denial? Yes. Or we've thought those words. So we can't help them make a quality decision if they're in the midst of denial. So how do we defeat denial? Any of you have tricks for me? Because I said lifelong learning, that's what I like to do, is perfect makes perfect, not just practice makes perfect. So what would you say or do to defeat denial?
Depends on where they're getting that information, because sometimes it's from an outside source. You've talked to them and they're ready for the program. And then this doctor over here has said or encouraged something that totally reverses it. Why is that doctor saying that? Sometimes it's not the family, sometimes it's the outside influence.
That is an excellent point. So sometimes they're getting information from a source, sometimes an outside source. They're Googling. I've been talking to families when they're actually Googling up delta aminolevulinic acid to see if it can be improved. They're looking for that. Well, you know, at Cleveland Clinic, they've got a specialty clinic for delta aminolevulinic acid, so that they're having that optimism and that sense of hope. Maybe that will be a miracle, but they're bargaining. They're looking for that. So that's right. And where they get the information. And you're exactly right. Well, let's see what the doctors say. Well, if you've got more than one doctor, then you're going to hear several different opinions about how it's going. You know, in the nursing home or in the hospital, maybe not so much at home, the doctor would say, well, she's not dying today. Why would you think about Cornerstone? Well, she might die tomorrow. This is a 6-month benefit, and we have the grace and care that can make her life the way she wants it to be. So if you have more than one doctor, then it's often, you make such a good point with that. But if you all want to interject, I want you to think of the hardest kind of conversation you've had, or one that just can't be solved, and let's see what we can do with that. But how do we defeat denial? Well, the way to defeat denial is to build an intellectual structure in them that they start to understand. So they start to understand, well, the kidneys don't work and they're not going to work, and the heart's too weak to start dialysis because that lowers the blood pressure, and the diabetes caused that, and you can't reverse the vascular effects of diabetes. Those are all the clinical things. But if we talk about all those clinical things, we give them an opportunity to deny that. Well, my neighbor had diabetes and their hemoglobin A1C went down. Now that can happen. So we're giving them this chance to deny, to disbelieve, and to bargain with us. So instead of telling them things that allow them to evoke denial, and almost anything we tell them, well, but this other doctor said, or the lady down the street had the same thing and she got better. You know these stories, don't you? And that one probably. So we don't tell them anything, we ask them. So we ask them. So can I have you as would you like to be a granddaughter or a daughter of a frail little old lady who's come from a nursing home to the intensive care unit? Would you like to be the granddaughter or the daughter?
The daughter.
The daughter.
I'm old enough to be a daughter.
Okay, so you're going to be a daughter. Thank you for volunteering. That was very nice. I saw your hand jump right up there. Hi, nice to meet you. A pleasure to meet you. I know this is such a difficult time for you. As I said, I'm Leonard Hock, and I'm here to help. So tell me about your mother. She was in a nursing home, and then something happened, and she came to the intensive care unit. How long has she been in the intensive care unit?
A week.
A week, yeah. What's happening? Tell me about that.
She just was declining. They didn't really take very good care of her at the facility.
They weren't taking great care of her at the nursing facility, and so she declined. Tell me about her decline. Was she eating okay and waking up and participating in activities at the facility?
She did. She was very active when she first got there.
When she first got there, she was active, but then?
Then she just started declining and didn't want to participate. She wasn't eating, and then she got a little confused.
Did she stay in her room most of the time?
They would always bring her out,
Mm-hmm.
and if she didn't want to. So.
But she was getting weaker, she was not eating. Did she have bowel and bladder accidents sometimes?
She was incontinent at times, yes.
Yeah.
I asked them to test her for urine and stuff, but,
Did you ask them to test that urine?
I did.
And what was your thought about that, testing the urine?
Well, if she had a urinary tract infection, it could be causing
It could be causing her to decline.
Mm-hmm.
Did she have a urinary tract
the
infection?
hospital says she did. And
Said she
became
did?
septic and has declined since then.
But they've been treating it.
They did not at the nursing home. They have at the hospital, yes.
But at 7 days in the ICU sounds much more serious than just a urinary tract infection.
She has pneumonia as well.
She has pneumonia, yeah. Was she choking on food and fluids or her own saliva?
They were going to do a swallow study, but they
A swallow study? But they haven't done it? Why not?
I don't know. They don't tell
Is
me
she
a lot.
strong? They don't tell you a lot? But you can tell me a lot. We've got her chart, her examination. I can look at all the x-rays. I can look at the blood test. I talk to the other doctors about what they say. But nobody knows her as well as you. Your whole life, you know her every look, her every smile, her every frown. When I want to know how she's really doing, I wouldn't open the chart. I would talk to you. How is she really doing?
Not well.
She's not well. Does she respond to you when you go to see her?
I feel like she does.
You want her to, right? But does she smile and hold your hand and want to?
Not really.
Not much, yeah. Is she sitting up on the bedside, starting to get better? Is she asking for more food? Does she eat? No? Gosh, how long was she in the nursing home?
6 months.
6 months in the nursing home. It must have been difficult even to put her in a nursing home, huh? Yeah. 6 months there. She declined there. Then in the hospital, 7 days in the hospital, not responding to her lovely daughter, not eating, not sitting up on the bedside. What do you think is happening?
She's probably getting ready to pass, going to die.
It's
I don't
heartbreaking.
want her to do that.
Of course, we don't want her to do that either. That's why she's in the intensive care unit.
Right.
We're doing everything possible. We want to see her get better. But her blood test and her x-ray doesn't tell us as much as you can. And it must be heartbreaking. I mean, I could see it, even saying that she's declining like that is difficult, isn't it?
Mm-hmm.
Tell me about her.
She's a wonderful lady. She's
Wonderful lady.
very kind, giving, very outgoing.
Did she raise a wonderful daughter?
Yeah,
Yeah.
and my sister
And-
and my brother.
And your sister and your brother. And what did she do to raise such a wonderful family?
She was just very loving. She was always there for us.
Yeah.
Supportive.
She loved her family.
She did.
Yeah.
She was the glue that held us together.
What a nice thing to say. She would be so proud that you would say that.
Mm-hmm.
You know
I just don't
what?
want her to die here.
You don't want her to die here? So that's interesting. If we could pull up another chair between us and put her in it, not the sick lady she is right now, but that bright, alert lady of 8 months ago or a year ago, and she could see all that she's gone through, from home to nursing home to decline at the nursing home to hospital, 7 days in the ICU. That's a long time of not getting better. If she could sit right here and I could ask her as a doctor, how would you want me to take care of you the rest of your life? Knowing how her life is going, what you've said, and you're correct, what do you think she would tell me?
She would want to be home with us and be comfortable.
So she wouldn't want to be in the intensive care unit talking about feeding tubes.
No.
She wouldn't want that. Has she ever told you that?
Mm-hmm.
She has? Even if she hadn't told you that, would you know that from the way she lived?
Mm-hmm.
You would know that. She wouldn't want that, but what would she want? She'd want to be home with us.
Mm-hmm.
Us means love, family.
Correct.
Home means comfort, safety.
Correct.
She'd want to be surrounded by her home, her place, her comfort, her safety, her family, love. But she'd want to be comfortable and cared for, wouldn't she?
Correct.
What would that mean? Would that mean maybe a nurse could come home and help her with whatever she needed, breathing or skin care, or
Right, or teach us how to take care of her.
teach you how to take care of her? What do you think we ought to do? Here she is in the intensive care right now. She wouldn't want to be there. She'd want to be home with you. What should we do? How would we respect her wishes?
Get her home.
Get her home. Okay, very good, very good. So do you all see the tech? Wonderful, by the way. And did you even feel her emotions? This is a hard conversation. And often when we do this in role play, I find that it becomes sensitive because in all of our lives we've had somebody that we love who declined and had their last breath. So that was wonderful. That was wonderful. But did you see the technique there? What did I tell her about her mother's prognosis? What did I tell her at all? I told her, I did tell her one thing. What did I tell her? I'm here to help. What else did I tell her about her mother's prognosis?
No.
Did I tell her her mother was going to die? Did I tell her her mother was terminal?
I hate that word.
Good for you. You hate that word. Don't use it. But do we know that her mother is going to die? How do we know that? Because she told me. She told me. So when she tells me, can she deny what she just told me? If I tell her, I've looked at her chart, her potassium's 2.1, her ejection fraction's 18%, she can't breathe, she's going to die. What's the first thing that happens? Denial and disbelief, and she hates me. And she hates me because I'm the one that told bad news. This conversation used to be called breaking bad news, but that's bad because we're breaking something and it's bad. So we've changed it to the difficult discussion. But difficult is a bad word, right? So now it's called the goals of care. And I did not ask, and did you hear my very subtle question? Not what kind of end-of-life care would your mother want. It is how would your mother want to live the rest of her life? End-of-life care and rest-of-life care is the same amount of time. Which words are going to keep them in conversation? The rest of her life. And did you hear then about what her mother would want? She would want to be home with us. So what does home represent? And you heard me say, Safety, comfort, familiarity. There is no place like home. I didn't make that up. And with us, what does with us mean? Surrounded by love and family. So home with us is powerful, right? She wants to be home with us. So did you really see any denial? I mean, you were a pushover.
I know.
You were a
I always
pushover.
am.
You always are?
Yeah.
Well, anybody want to be resistant? So tell me, what's the toughest case? I asked you to think earlier. What's the toughest case that you've had? Anybody say she can go to Cornerstone but she can't have morphine? Have you ever heard that one?
No.
Yeah. Or will she be able to continue her chemotherapy in Cornerstone?
Or dialysis.
Have you ever heard that one?
Dialysis is big.
Dialysis? Yeah. You want to do?
The word hospice, sometimes they say before you go to see the patient. They don't like to hear that word.
They don't like to hear the word hospice. So is hospice a word that will stop the conversation because of denial?
Yes.
Yeah. So did you hear me talk about hospice? I talked about what her mother's care needs and her wishes would be. Can we deliver skin care and medications and all of that at home? So we're totally honest. That's one of the principles of ethics, veracity, telling the truth. So if you ask, well, doctor, we would like to have her at home, or Leonard, you can call me Leonard. We would like to have her at home, but how would we get that care? How would the nurse come by? Is that home health care? We want home health care, because home and health and care are three good words, right? So, yeah, that would be a good idea. Well, it would have been a great idea in 1999 when home health meant that the nurse or the LPN or the aide came by and spent several hours with grooming and personal care and light housekeeping. But in 2000, home health care changed to monitoring. They come by once or twice a week, take your blood pressure, count your pills, and instruct the designated caregiver, not them, you, to provide that care. That's home health. It can be wonderful for a diabetic or a little lady that needs to have her blood pressure checked. It's a monitoring checking service. It's not a care providing service. So if you said, well, what kind of care could I get if it's not home health? Well, there is a kind of care that you can get, and it's the most generous benefit in all of healthcare in America. It provides doctor oversight, maybe a visit. It demands that a whole team looks in on your mother and your family. It requires that medications related to any diagnosis that she has that applies is covered. Durable medical equipment. If she needs a hospital bed or a bedside table to set her Chardonnay in the afternoon, we'll get her a bedside table.
And the Chardonnay?
Not the Chardonnay, but we'll get her the bedside table. We'll provide, if she needs incontinence briefs or that little dressing for that sore on her bottom, they provide all of that. That's the most generous benefit in all of healthcare, and they care. And you know a way they show they care? For the infectious disease specialist or the cardiologist or the pulmonologist, the patient is the unit of care. How is the patient's oxygen saturation? How's the patient's white blood count? How's the patient's tremor? But when you go to this kind of care, the unit of care is the patient and the people who love them. The patient, it's the only place in healthcare where you get this generous benefit. They'll do what your mother wants done for the rest of her life. They'll talk to the family. They'll support the family, and they'll be there. And you know what that kind of care is called? That kind of care is called hospice care. What do you think of that word, hospice?
It's a scary term.
What do you think of what I just said about the kind of care they provide?
It sounds very good.
Does it sound like what your mother would want?
Yes, but I would have to talk to my
You'd
siblings
have-
about my brother and sister about whether they would want hospice.
You'd have to
That's
talk to your
kind of
brothers and sisters whether they want hospice.
scary if they agree.
I'm so glad you said that. So your mother's wishes, you told me that if she was sitting right there, she would want to go home with us, right? And hospice care can provide medicines, a hospital bed, oxygen, dressings if she needs it, visits that would come. That's what she would want.
Correct. And I agree, but Mom.
But now you're going to ask your brothers and sisters what they want.
If they agree with the decision, I can't do it, I can't. Even
Yeah,
though
you're
I
a-
have the authority to do so, my brother feels like hospice kills people, so I would have to try to explain things better, maybe.
Your brother
you
feels
could-
that way?
Yeah.
He's not alone. A lot of people feel that
So
way.
I would have, maybe could bring him in.
Why do you
and
think,
talk to him.
of course. So you've raised two such important points. Why do you think your brother feels that hospice kills people? Is that perhaps because when people go to hospice, they often die?
Correct.
Yeah.
And talking about the medicine, getting him with, and I kind of understand how that all works. And
You understand.
Yeah. So to explain that to him, he feels like the medication's killing her because it's slowing
Yeah.
everything down. So he feels like.
So if your mother didn't go home with us and she stayed in the intensive care unit, what do you and your brother think is going to happen to her?
Well, I don't want her to do that, so I
You-
don't know
you-
what he thinks. I would have to ask him that.
You don't want her to die.
Not here.
But if she wouldn't want to die here because she would tell you, I want to go home with us. But if she continues her 7-day course in intensive care unit, as you have described, because you know her so well, she's likely to die in the intensive care unit. But the intensive care unit doesn't sound like a dying place, does it? It sounds like intensive care. But your mother's getting intensive care because we all want her to get better. We have the same goal that you have. But her body, her conditions, she's not getting better, no matter what we hope and want. And you've seen that and explained that to me. So if she's going to take her last breath, where would she want to take her last breath?
At home.
At home. So sure, I want to talk to your brother about that. Many people believe hospice means death. Hospice comes from the word. Do you know where it comes from, hospice? Hospitality. Come into my welcome. Be comfortable in my care. Hospice comes from hospitality. And it means when you come to us at Cornerstone Chapters, you're coming into our care and into our comfort. But it's a scary word because many people who come to hospice die. But I would like to think that in our hospitality, they live the rest of their life where they wanted to, with the people they wanted to live, and they got the comfort that every human being deserves, that respect. It's going to be tough to talk to your brother about that because words like cancer and terminal and dying and hospice all go together, and they're just such bad words. So I think it's important for me to explain that hospice is hospitality, about getting the care that your mother would want, where she wants it, with the people who love her, for the rest of her life. Maybe you can help me. You seem to understand very well, because your brother is part of who we're caring for. Because if he's worried about her decline and he thinks hospice means automatic death, then we need to comfort him as well. You know, it's interesting you would say that because hospice is not about hastening the decline. In fact, we've got some research that shows that patients in hospice live longer than patients who have the same condition that are not on hospice. And that's because they're not getting poked and tubed and plugged in and ventilated and x-rayed and MRI'd and medicines shoved into them. They're surrounded by their loving family, peace and comfort. Peace and comfort. So I asked earlier when I started to have really tough scenarios, the hardest case that you can think of. Do you all have any of those kind of questions? Have I said anything about good words? Would you like to go sit back at your seat? Okay, go back and sit. Thank you for being a wonderful daughter. Thank you for being a wonderful daughter. So words we use and how we use them, So when I sat down, I became eye level, which is human level. Of course, we do active listening. You remember the lean in and acknowledge what they say. But it's important not to tell, it's important to ask. This conversation I have turned the dialectical conversation, but I think more appropriately and every day, it's the ask, tell conversation. We ask. And do you see how we remove, but that other doctor said, you know that? The other doctor said. Did you notice how I removed what the other doctor said from the conversation? Oh, we have all the x-rays and blood tests. I can look at all the charts and consults, but you know your loved one better than anybody. So I removed all of those, but the other doctor said, because I've said we've looked at all of that. But you know your loved one better than anybody. Now, is that the truth? Do you think from a year ago she saw how her mother was? And when her mother went down that palliative performance scale, you know the palliative performance scale? When you get to about 40%, families can't take care of them at home. They're incontinent on the love seat. And often it's an event that takes them to the nursing home. But that's a powerful emotional time in any family's life. When you go to a nursing facility, you're already frail and debilitated, and when you decline for 6 months, who do you think sees that better than the family? No one. Pardon me. And in the intensive care unit or at home, people that love them, the families, see that decline. So we don't look at the MRI or ask the nephrologist how she's doing. We ask the people who know her and love her how she's doing. And they will tell us. Well, you've told me she doesn't respond, she's not eating, she can't sit on the bedside. And the question is, what do you think that means? And there is the defeat denial question. What do you think that means? I can tell you all day long that she's going to die, and all day long you won't hear those words because of denial. So I appreciate you all very much for being here today. I hope maybe some of the words that I have used or some of the techniques, knock, acknowledge, introduce, sit down, how can I help, and tell me about your loved one. Often that tell me will be, she's the best mother ever, she taught me how to make peach cobbler. That'll be the personal side. Or let me tell you, she was well until she had that little stroke. That's the clinical side. Sometimes they go together, but we listen with empathy and compassion, and that shows we care. And you all care, and I'm very proud of you. Thanks very much. Thank you.
Thank you.